My name is Dr. Patrick Arkash. I'm in charge of the Orofacial Pain Clinic at the Faculty of Dental Medicine of the University of Montreal. Welcome to our video on fitting and adjusting an occlusal splint. This is part of a more complete webinar series on temporomandibular disorders and sleep apnea. Occlusal splints, also called full coverage splints, Michigan splints, or stabilization splints, have been used for decades to control the effects of bruxism. Mainly protect the teeth from attrition and wear, reduce masticatory muscles pain, and reduce TMJ pain and pressure. Even though the exact mechanism of action of the splint is not perfectly clear scientifically, we do have decades of positive clinical usage around the world. We hope you enjoyed this video. If you did, please follow us for the complete series of videos on temporomandibular disorders and sleep apnea. Traditionally, occlusal splints have been used on the maxilla. However, insertion on the mandible is easier and more comfortable for the patient. More so, some studies have linked the use of maxillary splints with an increase of snoring and sleep apnea. However, they are still indicated in cases of severe class 2 and of course if there are some teeth missing on the maxilla. The instruments needed are 2 Miller forceps with 2 different color occlusal papers, one to mark the centric, one for the eccentric contacts, a straight handpiece with 2 different acrylic burrs, one large, one tapered, an examination kit, a ruler, and of course the occlusal splint. So first, the splint is examined on the model, making sure there's no rocking motion, right to left, front to back. The adaptation is also checked, and then it is transferred to the mouth. The splint is then transferred to the mouth, and the adaptation checked and verified. No rocking right left, no rocking anterior posterior, and comfort for the patient. In this case, the splint is still a little bit too tight on the 2 canines because they are buccalized. So the inner side of the splint is adjusted where the canines are. It's normal that the patient will feel that the splint is a little bit tight in the beginning. That's to be expected. But it shouldn't be painful. So the splint is checked again, and then the bite should be adjusted. We use Miller forceps and AccuFilm marking papers. The paper is placed on the right first, and then the patient closes his mouth. Fermez la bouche. No, en arrière. Voilà. Then the patient taps his teeth a few times. Allez-y, tapez plusieurs fois. Merci. Ouvrez. Tapez plusieurs fois. Merci. Ouvrez. Tapez plusieurs fois. We can feel that the patient has a tendency to go into protrusion, and this should be adjusted. These are the markings we have, and they should be even. So with your acrylic burr placed flatly on the splint, you will remove the prematurities or the premature contacts and adjust your splint till you get even bilateral punctual contacts on the functional antagonist cusps. Tapez plusieurs fois. Okay. Allez-y. Tapez plusieurs fois. Merci. Allez-y. Tapez plusieurs fois. Merci. Et encore. So after a few adjustments, this is how your splint and the contacts on the splint should look like. Even, bilateral, simultaneous, punctual contacts on the cusp tips only. Anterior contacts slightly lighter than posterior contacts. After your CR contacts, we're gonna adjust the cuspid guidance and anterior guidance. The goal is to have a cuspid guidance and no contacts at all on the rest of the teeth. No interferences other than the contacts on the cuspes. We can see that we do have some interferences here. We should adjust this, and we don't have a continuous line on the other side. So the splint should be adjusted in order to have this. So after a few adjustments, this is how your splint should look like. Lateral guidance on the canines and anterior guidance on the incisors, making sure you have straight lines in the anteriors and oblique lines on the canines. No contact on the posterior teeth. The splint is then polished using a polishing wheel on the Red Wing engine. We polish all around, just making sure we have all the surfaces very smooth for the comfort of the patient. After polishing, we place the splint back in the mouth, making sure that when the patient closes, it's smooth, comfortable, and the contacts are bilateral and even. So the splint is placed in the mouth and checked for good fitting and absolute absence of rocking. Then the patient closes, rest for 2-3 minutes just to make sure there is no pain or no discomfort. We're going to proceed after that to the adjustment of the occlusion on the splint. So first of all, the centric relation occlusion is checked. The Miller forceps with the articulating paper is placed in the posterior segment. The mandible is gently guided into centric relation, and the patient is asked to bite 2-3 times. And the other side. The splint is then removed and the adjustment proceeds. The occlusal splint is placed in the mouth and checked for good adaptation, absolute absence of rocking and discomfort. The patient closes and we wait 2-3 minutes just to make sure everything is okay before proceeding to the occlusal adjustment. The contacts are adjusted till we get the ideal occlusion, meaning bilateral, punctual, even contacts posteriorly between the canine and the second molar is present, and anterior contacts slightly lighter in centric relation. Normally you're going to need 3 to 4 adjustments in centric relation, 1 or 2 in lateral guidance and 1 or 2 in protrusive guidance. The CR occlusion is established, making sure we have point contacts on all the antagonist functional cusp. The contacts are even and bilateral from the second molar to the canine, and slight contact on the anteriors. Once the posterior occlusion, the CR occlusion is established, we're going to go to excursive movements. We're going to place a different color articulating paper. The patient is going to close and then grind his teeth. Bougez à gauche, à droite, exactement. L'autre côté aussi. L'autre côté. Merci. Merci. Fermez. Et graciez en avant en arrière. Merci. So after the posterior CR occlusion, the excursive contacts are adjusted till we get on the lateral guidance only on the cuspid, so it's only cuspid guidance, no posterior contacts at all, and on the anteriors slight straight lines, contact on the anterior teeth. Absolutely no non-working interferences, no contacts on the posteriors in lateral or protrusive movement. So after adjusting the occlusal splint, the splint is going to be polished, then retried and checked in the mouth, and the instructions given to the patient. Instructions are given to the patient. Clean daily with a soft toothbrush and liquid hand soap. Rinse thoroughly. Keep immersed in a water container or wrapped in a wet towel. Soak in a disinfecting solution 2-3 times a week, ideally every day. Get used to the appliance gradually for 2 or 3 days before using it all night. Careful not to leave it on a countertop if you have a pet at home.